Repeated movement testing is the #1 orthopedic test I use for diagnosing orthopedic disorders. And this is in stark contrast to 90+% of people who work in orthopedics out there in different types of professions. Most people who work in orthopedics are going to be diagnosing based on quick pictures like MRIs or X-rays, or quick orthopedic special tests or clinical tests that oftentimes can be completed in just a few seconds. As I like to say, repeated movement testing is a living and breathing test. It's algorithmic, it's cause and effect, and it investigates the question: if we change this one variable by adding this one movement to your life, for example, knee flexion, or neck left side bend, or shoulder internal rotation, what happens to all the signs and symptoms that we've measured so far? Now, we do repeated XYZ testing in lots of fields of medicine. It's not a foreign concept. It's just not called repeated XYZ testing. For example, if you have depression and you're working with a clinician to figure out which pharmaceutical agent is best for you, that clinician will decide which one to start with, how long to give it, and what to change if the desired results are not attained. So they may start the patient with X, and then after 4 weeks or 8 weeks, change it to Y. But it's not called repeated depression pharmaceutical testing. It's just an informed investigation. The same may apply to someone who has a gut problem or health disorder mediated by the gut. There may be different dietary regimens to test. You may try a low FODMAP diet and then a low histamine diet, or maybe a ketogenic diet. The doctor or the clinician will decide how long that regimen should go on for. They will know how long to give it before they would possibly change the dietary plan. Some people call these types of investigations trial and error, but I really reject that thesis. Trial and error, of course, we all do to ourselves all the time. But when a clinician is doing a protocol based on an evaluation of a patient, it's more an informed investigation. It's not just throwing things on the wall and seeing what will stick. When I do an orthopedic evaluation, it's 3 parts. And the first part is a specific verbal history. And the second part is taking all the baselines, all the metrics, nerve tension, strength, balance, range of motion, etc. And based on all that data, and based on the patterns of the thousands of patients I've worked with over these last 14 years, based on what I've learned in textbooks and from mentors, all that data is helping me decide, do we need to do a repeated movement test? And if so, which one? Does this patient possibly need ankle dorsiflexion? Or do they need shoulder horizontal abduction? Or maybe lumbar flexion? And doing that movement will give me data on whether or not to continue that movement, add more force, change the movement, etc. So it's repeated movement testing, assessing the effect of doing one movement repeatedly on all the signs and symptoms. And like I said, this happens in all fields of medicine. We just don't call it that. So while it seems very foreign to people in the realm of orthopedics, it's not a foreign concept to change a variable in someone's life and intellectually assess how it changes their body. In orthopedics, we're almost always in mainstream orthopedics saying it's a structural problem because a fancy picture tells us so, or it's something kind of more ethereal, like IT band syndrome or patellofemoral pain syndrome, these kind of vague pathophysiologies. Yes, I find structural problems in rare cases when there's trauma usually, but I don't believe in those other kind of vague concepts of how the musculoskeletal system breaks down. Repeated movement testing, when you do it correctly, will show you that most orthopedic disorders, at least 70%, will be fixed if you mechanically move a joint in one direction, and it can also be worsened by mechanically moving the joint in other directions. So it's not just try this motion and see what happens. It's based on a lot of data that we choose which movement to test, how the patient responds to that movement done throughout the day, usually every 2 hours, informs where we go next. It requires a bit more patience for the diagnostic process, of course, but on the back end, we save a lot of time because we are confident in the diagnosis before we start the treatment. I tell patients that it might take 4 visits to get to the right motion, but after we find that movement, we're basically close to done. But if on day 1 you started off because you thought it was a tendinopathy and it wasn't a tendinopathy, it was actually an elbow joint derangement, well then you've already spent several visits, if not many more, treating a tendinopathy without results because you had the wrong diagnosis. So I urge people, if they're struggling with orthopedic disorders, to find a clinician who uses Mackenzie's repeated movement testing at a high level. You can also buy the books and do some self-investigation, which, unlike working with a clinician, is a little bit more on the trial and error side because you don't have that training or experience to know exactly how to interpret the results of the repeated movement test. But nonetheless, those books help a lot of people. Treat Your Own Back, Treat Your Own Neck, etc. will walk you through the process to the best that a book at home can. But find someone if you're struggling, because I believe that the best way to figure out a lot of medical disorders, especially orthopedic disorders, is to decide which variable to change in someone's life, just one or possibly two, and assess the effect versus throwing everything at the patient, which is what I used to do, like strengthening, stabilization, stretching, mobilization, maybe some electric gadgets, maybe some heat or ice, maybe some other fancier manual therapies. By finding the one movement or investigating for the one movement, the picture becomes clearer.